superficial things that we know pretty well, like the delts that are easy to add on, okay? Then next week we're going to do arm, upper arm, lower arm, and hand. And then that last week we only have like 2.5 days before spring break, so we're just going to do something like an anatomy trains brief. What? Yeah.
We're just going through the developmental sequence today?
No, that's just like the preface for the structure of the cervical.
Okay.
So we're doing cervical and shoulder structure, not necessarily the muscles, but just the foundation of like the actual structure. Okay, so this has a tendency to get a little bit difficult because it's everything from our head down is sort of our brain stem, all of our nerves that integrate out of our body. So everything runs through this, down and out. So it's very fine tuning and it's very easy to get off, okay? So top of the head, what we need to know is this is the occiput or occipital. It can be called either. So occiput or occipital. And then our neck flexion and extension are 50% of our motion of our neck flexion and extension are through that joint and the first C1, which is also called the atlas. So if we flex our neck or extend our neck, 50% of that range of motion comes from this segment. And the remaining 50% comes from the rest of the neck. Yep. So flexion and extension, 50% comes from there, and the other 50% comes from the rest of the cervical, which is...
Is the C1 a part of the occipital?
Well, it's sort of this joint. So it's occipital and then C1. That is two segments that make a joint range of motion, yeah. So those two, so kind of the base of the skull in the first C1, 50% of our flexion and 50% of our extension come from there. The remaining 50% come from the rest of the cervical vertebrae. That's just flexion and extension. So our main two, the only ones that are called different are the C1, which is atlas, C2, which is axis. So 50% of our rotation of our head, going side to side, comes from our atlas and our axis, or C1, C2. So if I can turn my chin all the way to here, 50% of that comes just from the first two, and the remaining comes from the rest.
C1 is called atlas?
Yeah, you can call it, they're synonyms. So atlas or axis, C1, C2, yeah. I don't know why they decided to give them special names.
So the occipital, back of skull, C1 and C2.
Yes.
Oh, sorry. I was reading you my notes. The occipital, C1 and C2 make up 50%. Yeah.
Okay, so inflection, in extension, 50% of that comes between the joint of the occiput and C1. So right here, these two things, if they're moving well, 50% of the ability to take my head back comes from here. Then 50% of my ability to rotate my head comes from C1, C2. And the remaining 50% of that range of motion comes from the rest of my cervical spine. So there are entire disciplines within chiropractic that's called NUCA, which works just on the atlas and axis. So their entire philosophy is that, and this is true, that the eyes need to be level. So the body will always make the eyes level. Some disciplines work from the feet up, some work from the eyes down. It all kind of works itself out. But some disciplines work just on C1, C2. If this is out of whack, they think the rest of the body works around to compensate for it.
It's called NUCA.
NUCA, N-U-C-C-A, is a specific type that just works on atlas axis. That's all they do. It's pretty crazy. I had it done.
What do they, how much can they do?
How many?
A lot. I mean, it only takes small changes to make big differences down the chain.
Yeah, it changes a lot.
Yeah.
Like when I got my concussion,
What they do in that is they actually they'll take a bunch of x-rays and look at how the C1, C2 relate, and then they will work on a hands-on technique to have them just a subtle change and then how the rest of the structure adapts around it. So I've had it where Jen, remember how you hyperextend your knees? I was hyperextending my knees at a time, and by adjusting my C1, C2, I stood up one time, my knees didn't hyperextend anymore. It's crazy. Yeah. Mm-hmm.
So what's like the whole area?
Cervical. So the neck is the cervical.
And then how many?
7. 1 through 7, C1 through C7 is the cervical. Okay? So, and if you turn around here, so I mean, this is just the sort of the blood supply. There's so much stuff that runs through all of this, right? Like everything kind of runs through here. So our C1 and our C2 have a little bit different structures than the rest of the vertebra going down in the neck. So if we look at the first right here, so C1, and if you click on this right here, it will pull it out, and you can look at just it, and you can see how much structure is just in that. So all of those different colors are different bones within that one area, that one vertebra. So there's a lot. And those are all called articulations when they connect from one to the other. So those are all the articulations just in your first cervical vertebrae, which is insane, right? There's a lot. That's why I'm saying we just barely touch the surface. Like, depending how deep you want to go, there's an endless amount of depth. If you're a spinal surgeon, you better hope your guy knows this, right? Because he has to go through all of this, then all of the muscles and all of the nerves into a herniated disc and just work on that disc and come out in a small little slit. So, I mean, there's a ton of stuff that we have to know. We just kind of surface learn it, but know there's a lot more to it. Okay? So, let's pull back out of this. Here's the difference. So if you see it, well, let me go in. So there's not really a fin on this. So this is the back side. There's not really a fin because we can get a lot of extension. I'll tell you what you need. So here, we start to, pay attention, the rest of the cervical have a little bit more of, looks like almost a fin. So it keeps our joints from going too far back. Okay? So let me give you a little bit more. C6 is a decent example of what they all just kind of look like. So right here is a general view of what some of our cervical look like. They all are slightly different, but they're similar, okay? So in the front of the cervical vertebra, this is called the vertebral body. So know this. This is the vertebral body. So if this is me facing this way, this is the vertebral body in the front part of it. Yep. I'm not going to make you know all of them, but just a few of the important ones. They're all important probably, but the more obvious ones. So vertebral body is just kind of the front part of the vertebra. It's easy because it's got the name in it, right? Vertebra, vertebral body. Then the opposite side of that in the back is the spinous process. Don't worry about all of these that have the back of those are called the spinous process. So spinous process is right there. So we can kind of feel or see some of those if someone ducks their head down and flexes, the spinous process. And then if we want to go straight to the side of it, we have the transverse process. So right here is sort of the transverse process. So transverse means side. So we have the vertebral body, and then the spinous process back here, and then the transverse process. So those are just sort of the contact points of our neck. And all those vertebrae just kind of stack upon each other. But slightly different shapes. They get a little bit smaller as they go up, and a little bit thicker as they go down. And they all just kind of rotate and move on each other.
Which one is the transverse?
Transverse is side. If you just know this general area as a transverse, I'm good with that. If you want to know exactly, let me come off it. This, what's going to become blue right there. So this is the transverse process. Right there. And each of the vertebrae have a slightly different look. So if this is C6, and we look at, let's see, C3, it's a slightly different look. Every single one is just a little bit different so that as a whole we get full range of motion. So they all just kind of work together, but all by being slightly different, we get full range of motion, or what our full range of motion is. Transverse process. Transverse process is this, well, let me go back to that view for you.
So each one of them is different? How are you?
They're slightly different. I'm just going to show you C6 and go off of this because I want you just to understand the process. So this is transverse process. Transverse meaning side. So if those kind of run into end range, it's the transverse process on the side. So we move transverse. Okay. Yes. Yes. Avery, make sure you get this. This is just one of the vertebra. They're all slightly different. So if we click into C6 right here, the front of the vertebra, so this is the front of the head over here. This is the vertebral body. So it says it right there. That's vertebra. Just add the word body to it. So if I click on it. And then the back side, the opposite of that. So straight back here, if someone flexes, that's real thin, you can see that. Right back here, that's the spinous process. Just know it as the spinous process. Yeah, this right here is the spinous process. Right there. So, yep, right there. And when we go into extension, they all kind of stack upon each other. And then laterally, yeah, spinous process. Don't worry about anything other than that. I just want you guys to have a general understanding of how those work. If we learned each of them, that would take a while. And then if I make this right here go blue, this right here is the transverse process. So this right here, this now is blue, is the transverse process. Each side has a transverse process. So those are kind of three landmarks of the vertebra among all of those. So articulation is just, so any of this one right here, so any of these other ones that's a different color is a different articulation. Yeah. Got it, Avery? Okay, so going back to the straight visual here. So we have all our nerves that innervate or run out of these canals, okay? So typically, most of our nerve innervations don't start till C5. Anything above C5 and you break your neck there, that's usually where you're paralyzed, like quadriplegic, okay? Anything farther down, you have more nerve function. So from C5 down, we start to have some specific nerve innervations, which let me go right here. So our body kind of scrolls itself down like this. So it reciprocates down. So if we hurt C5, if we, let's say just right now, cut off C5, or just inhibited C5, the nerve that innervates C5. Let's see. That is anything that's our delt or our bicep. So if right now, if you were just able to stop only C5 on me, my bicep wouldn't work. In my lateral delt. Yeah, I'm just saying like as an example.
Would your fingers move?
Yes. We'll get to fingers. Yeah, certain nerves innervate certain areas. So most times you don't just hurt a single area, but that's just an example. Like the nerves that run through C5 go to the delt and the bicep. And that's the ones I'm making you know. Like, yeah, I mean, there's a million things that are function, but that's like a general. Let me see. So C6 then. What do we have? So the thumb, among other things, the thumb. So if you are sitting for a long period of time or writing or doing whatever and that thumb starts to just go numb, it could just be nothing, but if your thumb is tingling and nothing else, sometimes it's the nerve being pinched at C6, and it's just the numb, just a thumb. Well, none of what we're doing. Like starting at C5 is where we're going to start. So C5, C6, C7.
Wait, I thought from C1
From
to C5 was like that would make you paralyzed.
C rough, yeah. I mean, so that's why beginning at C5 is the first nerve innervation that I'm having you guys learn. C7. So if we're at the 7th cervical and something happens, we herniate a disc, our tricep. So if you think of an example where someone had a tricep limitation, Peyton Manning, when he had neck surgery, one of the reasons he wasn't sure if he could come back and play was his tricep. He pinched or injured or herniated the disc of C7, so his tricep function started to fade away. And then with that fade away, he couldn't follow through and he couldn't throw a football. So he had to wait for his nerve from C7 to regenerate, to activate his tricep so he could strengthen it before he could throw again. So that's why he missed a year. Nerves regenerate at about, if they do it all, 1 millimeter a day. So 1 millimeter a day. A nerve regenerates. So down wherever it's connected to. So that's why it takes longer in my case with the leg, right? So if I hurt my lower back right here, and the nerve innervation goes all the way down to my big toe, if that is inhibited, and now let's say it's turned back on, it still will take 1 millimeter a day all the way down to get to that toe. So that's like 500 days.
I don't get what regeneration.
Regeneration means okay, think of like the light switch was cut off to it, and now the light switch is back on. It takes a while for the signal to get all the way down there again. From here down. So if I got hurt right here, that signal went all the way down to my toe, even though this was repaired.
But it would take a millimeter.
A millimeter a day. Millimeter a day. It's okay. Well, that's a huge process. All right. So this to me is the most confusing when they say C8. There is no actual C8. The C8 is the difference between C7 and T1. Some journals will call it C8. Some will call it C7 to T1. So that's just the space between those, right? So it's the space between things where the nerves come through. So between C7 and T1 are the last two of the fingers. So if these fingers just go completely numb and stay numb, a lot of times it's between C7 and T1 that was inhibited or pinched or aggravated.
Do we have to memorize each, like what?
Yeah, that's why I only gave you 2 for each of those.
So thumb for C6.
Tricep for C7, last 2 fingers for C8, for C5, biceps and delts. Yeah, that's like very minimal on the grand scale of how much there already is to that. Because think of all the stuff we are able to do just in our arms in general. All right, so if we want to evaluate our cervical spine, we have a few ways that we want to look at full range of motion. Okay, so we talked about sort of the flexion and extension. So in our position, if we're evaluating someone, we want to see can they get full cervical flexion. So if the tongue is on the roof of my mouth, meaning my mouth is just closed, can I bring my chin down and touch my chest? So just my collarbone right there. Can I bring it down and touch? So this is just cervical, can we get flexion? So full range of motion, instead of degrees, is just chin to chest. Okay? Then the opposite of chin to chest is looking up. So can you get your face horizontal to the ground or the ceiling? I cannot. I'm very limited in that. I'm very limited in my neck extension, and therefore that's going to put me in a bad position, right? If I'm limited in that, in the cervical range of motion, I'm more likely to get injured. So cervical flexion, cervical extension. Know the range of motion of each.
Cervical flexion.
You mean the range of motion?
Just what so you would say, so I would say, how would you screen the cervical for range of motion? You would say flexion, chin to chest, extension, face parallel to the horizon, which would be ceiling or ground, right? Then we have rotation. So to be able to go, if this is straight ahead and this is 90 degrees, to be able to go 90 degrees. To be able to rotate 90 degrees each side without changes in my shoulder posture. So a lot of times we can get things by changing the rest of their body. It should just be in the cervical. Remember, we have 50% of it coming from C1, C2, and the rest is coming from the rest of the cervical to be able to turn this far.
45.
90, yeah. So 90 degrees of rotation and 90 degrees of rotation this way.
So if rotation is limited, it's most likely in an axis.
That would be the first guess, yeah. Yeah. That would be the first thing you would assume because it has the greatest percentage. Okay? So we have rotation, and then the last combination is rotation plus flexion is bringing the chin to the clavicle or collarbone. So to be able to rotate and go down without, I can do this, I can raise my chin to it, but just staying down and being able to go right there. Rotation plus flexion.
What's it to?
Clavicle or collarbone, yeah. All right, do you guys have those? So now, if we were going to look at that as a group of everybody, we would, if we know the developmental sequence, so we learn from the bottom And then as we get more stable, we become more vertical. So in theory, this is my highest level of stability of all those positions. So if I can do that, all those ranges of motion standing, then I can, in theory, do them on kneeling or hands and knees or laying down, right? So those are the 4 positions that we can look at them. Standing, which is the highest level of stability or motor control. If someone cannot do it standing, but can do it kneeling, then somewhere along that transition, their motor control or reflexive core can't stabilize them standing up, but can stabilize them in this position, because this is more ground support, okay? Then if they cannot do it here, hands and knees or quadruped, like a crawling position, you would do it as well. And if they cannot do it there, you could look laying down. So a lot of times someone can do it laying down and then can't do it standing up. So they have the range of motion, they lack the reflexive core to be able to stabilize the body. So for some reason along the line, it stiffens up and doesn't allow it. So it's not a stiff neck in that case, it's a reflexive core. The better this gets, the better this will just relax and your range of motion will get better. If we just stretch that person all the time, they're not going to get better range of motion. They're probably going to get worse because their body's protecting them. They're protecting that spine. It is crazy. All right, and to add to that, there are 4 possible outcomes for each of those. 4 possible outcomes. So if you're looking at me in this position, and you're looking at my neck range of motion, 4 possible things for each of those: flexion, extension. Okay, so in flexion, I can either be functional, non-painful. That's just being able to do it. Functional, non-painful. That means essentially I can do it, right? Functional means I can do it. Non-painful means it doesn't hurt. Functional, non-painful. I can also be functional, painful. I can do it, but it causes pain. Neurologically, that's a big difference. Okay? So if someone has pain in the range of motion, we're going to look lower. We're going to try to find where they don't have pain. Then we might have dysfunctional, non-painful, meaning I can't do it, but it doesn't hurt. So if I can't touch my chin, but it doesn't hurt, I'm dysfunctional, non-painful. And finally, if I can't do it and it hurts, I'm dysfunctional, painful. So those are the 4 little boxes that we would check. So we'd write any of those as just abbreviations to each of those movements. So you might have somebody that can do 3 of them but can't do 1 of them. That's going to tell us where to look at and start to explain it. So we can peel away. We can remove whatever's fine and just look at what's not. Remember, everything's just a big net. So if we can find it, then we can fix it. Okay? Any questions about that? Because that's just 4s and 4s and 4s. It's logical, but it just kind of adds up. Right? So cervical, we have the ranges of motion. Then we have the 4 positions that we could screen it in and the 4 possible outcomes of each of those. Good? Okay. So now we have, let's go into, all right, shoulder range of motion. So if we want to look at shoulder as just the structure, none of the muscles yet, right here, blue is clavicle or collarbone, kind of synonymous. Clavicle or collarbone. Runs right across here. Kind of meets up in the back with the scapula that essentially ends up making what we call a shoulder, right? So the scapula is right there. I'll move it up.
Wait, clavicle is like a part of the rib right now.
Clavicle is what?
Is it like a part of the rib?
It's not. It's not a rib. It's above the rib. So this is the first rib right here. It goes right above that, the clavicle. So it kind of looks like a rib. It just doesn't attach on the spine. It originates from the front versus the back of the spine.
And then what's the other one? Clavicle and the
Scapula. So clavicle and scapula together kind of make up our shoulder joint. From that, there are many different joints, the AC joint, different things like that, depending on where it connects. But that's what, here and here is our shoulder joint. So if you can see now, just the function of the ribs and the function of the scapula. So when we talked about thoracic spine being able to move correctly, you can see now if the thoracic spine on this side is stiff or stuck in flexion, how limited this scapula is going to be. If I can't extend my thoracic spine this is already going to be put in a compromised position. So a lot of times shoulder issues are not really shoulder issues, it's thoracic spine issues. So if I can't move my thoracic spine, this is obviously not going to move as well and maybe cause problems. So always look at the thoracic spine first, but understand for our structural sake, clavicle, scapula. We'll layer the muscles on it tomorrow, not today. All right, and then range of motion of the shoulder, just like the neck, okay? So here, flexion, if this is our anatomical position, flexion, 180 degrees. So roughly straight up, right? From here to 90 to 180. So that is dependent upon the fact that my thoracic spine can move fully, right? If I'm stuck in kyphosis, I'm not going to get that. And therefore, I'm going to aggravate and put my shoulder in a bad position, and probably I'm going to hurt my shoulder eventually. So 180 degrees of flexion, right here, about 60 degrees of extension. So this is flexion, this is extension. So to extend my arm back, 90 would be straight back, just past 45, so about 60 degrees of extension.
60 flexion.
180 flexion, 60 extension. So if this was here and that was 90, going straight back, I'm a little bit past 45, I'm 60.
But I thought the flexion was on like
I know, it's flexion, it gets a little tricky sometimes. Joint specific can vary. That's why I'm just saying, just memorize that. Because this is bicep flexion too.
extension 60, 180 flexion.
Yes. All right. Then, if I'm in this position, so if we lay down, we'll look at it. So in this position, internal rotation. So if this humerus is internally rotating in the socket, coming in, 70 degrees. So if I'm laying on the ground, I can't quite get my hand to the ground, but I'm close to it. So I'm 70 degrees of internal rotation. A lot of times, we'll get farther by compensating in the shoulder, but if we really keep this locked down, about 70 degrees of internal rotation. So most,
Go for standing too.
laying down is the more accurate way to look at it because we kind of put the torso in a locked position. So a lot of times our dominant arm side will be less internal rotation. So when we do this and break it out, our dominant side will be worse at this in internal rotation. So it'll be worse going this way. But the opposite of internal rotation is external rotation. 90 degrees of external rotation. So again, back to this is our neutral. So if we're here, 70 here, back to here, 90. So if I'm laying on the ground and my arms straight up to the ceiling, my palm should basically, back of my hand should get to the ground, just comfortably. So if I'm laying down, it's just here. So if it's here, and this is the ground, it's just, can this get to the ground? So we have, this is 90. This is external rotation. This is internal rotation. I'm kind of a bad example because mine's limited. 70 for external, or 70 for internal, 90 for external. So shoulder range of motion, 180 flexion, 60 extension, 70 internal, 90 external. Okay? So first things we're going to look at when we look at shoulder function is we're going to look at neck range of motion, thoracic spine, and then shoulder. Okay? That will almost tell us everything we need to know. From there, we can get more specific. Okay? Any questions about that? Tomorrow, we'll go down and just do our movement stuff, and you guys can ask me questions. Tomorrow, we'll add some of the intrinsic muscles on this structure, and then we'll add some of the more basic stuff the next day, which is a lot easier the last day.
Do we have time to go down to that?
Yeah. We have 15 minutes. I can talk. I can teach more if you guys want. We can add more.
Wait, can you just go over like the, I don't really get the
Yeah. Ask.
C5 or the, what were the specifics that you were talking
Okay.
about?
So
All of those
let's do this. That's fine. I'm fine with that. So let's just go. C1 is also known as atlas. So if we're looking at what we just said, those flexion extension ranges of motion, let's say I'm lacking that. And I'm lacking that in all of my positions. Even lying down, I'm lacking that. 50% of my flexion comes between these two joints, right? The occiput and the atlas. Does that make sense? Know that. So 50% of it comes from there. Flexion and extension. Both, yep. Both. Then, if I want to look at 90 degrees of rotation, right? So 50% of my 90 degrees of rotation comes from C1, C2, or atlas and axis. They rotate. 50% of my 90 degrees of rotation comes at those two vertebrae. And the remaining makes up the difference. Okay. So, cervical we have C1 through 7. Yeah, okay. So now there are nerves that innervate stuff above that. I'm not making you worry about that. So what I'm making you worry about is from C5 right here. So between these two vertebrae, nerves come out. Nerves come from the spinal canal out, and they go down. Those ones that we need to know are our deltoid and our bicep. Our deltoid and our bicep. So if for whatever reason you shot an injection into that area and just numbed mine, I wouldn't be able to feel my deltoid or bicep. Those would be directly related to that. Okay? Then one segment below that, what they call C6, among other things, we're just going to make you know the thumb. So the thumb would be unable to give thumbs up. Would be stuck.
Does anyone have gum?
Good job, Jen. Thanks. C7, triceps. So the nerve that comes down here innervates down into the triceps right here. So that is why Peyton Manning couldn't throw a football. That nerve was, the blood supply got cut off enough of it by probably a herniated disc, and it's just like an electrical switch, and it just ran out of impulse, and then the tricep just kind of shrunk up and wasn't strong or powerful. Once that disc was fixed, it wasn't an instant fix, the nerve still had to regenerate. So that nerve impulse still takes 1 millimeter a day. So from here down to here, that's a pretty good amount of time for 1 millimeter a day. For the lower back down to the leg, even longer. It's like 500 days sometimes to just regenerate that nerve injury. That's why the body is so guarded of the spine, because it takes a long time to get better. It's way easier to protect it. And then between C7 and T1, our last two little fingers. Right there. The last two, yep. The middle finger starts to kind of split between different. I'll show you an image next time that kind of shows where the split is. And then be able to understand neck range of motion. And then the 4 positions that you would screen that in and the 4 possible outcomes for each of those. Does that make sense? Yes? No? Yes? And then shoulder range of motion. Well, this is only structure. There's not even muscle yet. And then within just a vertebra itself, be able to we're doing very few of these. So the vertebral body, the spinous process, and the transverse process in an image. Just be able to spot that. All of the colors are different articulations within the joint. So there's a ton. We're just doing a few. Okay? All right. You guys can just study or do whatever until then. Tomorrow we'll add the muscles. Tomorrow we're going to do like more intrinsic muscles.